Hello, in this lesson we are going to be covering death, dying, and hospice. We'll get into what hospice care is, how we can assist patients with hospice care with the death and dying process, what to do when a patient or if a patient passes away, how to handle it, the care that needs to be given as well. Hospice care is a compassionate way that we can care for a dying person and their family. What it uses is a holistic, person centered approach by treating the patient with physical, emotional, and spiritual, as well as social needs. This can be given 7 days a week, 24 hours a day, and is available with the doctor's order. It can take place in several different settings, such as a hospital, a care facility, a nursing home, or even in the person's home. It can be given by any caregiver, but is often given by trained nurses and volunteers. The whole goal of hospice care is to provide comfort and meet the needs of our patients' physical, emotional, social, and spiritual. Within hospice care, what we want to make sure of is we're doing everything we can to make our patients as comfortable as possible. The nurses will be giving medications that will assist with pain. As CNAs, you will be bathing, providing incontinence care, mouth care, and oral care for especially for patients that may be unconscious. Repositioning patients to assist with comfort in reducing pain, socializing, supporting not only the caregiver, the patient, but the caregivers or the family members as well. Really looking at the person, once, like we said earlier, as a holistic. So the whole person and the family, and doing everything we can to care for them. So Dr. Kubler-Ross came up with the 5 stages of dying. And it's important to note before I go through all these, not every patient or resident is going to go through all these stages, or are they going to go through all these stages in this specific order? These are just the different stages that they came up with. Some people do go through these in the exact order that they're listed here, but some jump through some of them, some don't go through any of them. All right, so the first one we're going to talk about is denial. This is when they refuse to believe that they're dying. They don't believe it's going to happen to them. It's just complete denial about death and dying. The anger stage is where they're, why me? What did I do? How come this is happening to me? They're very angry. The next stage is what we call the bargaining stage. Okay, I'm dying, but give me 5 more days or give me a month or whatever it may be. They're trying to bargain their time they have left. Another stage is depression, where they need to mourn and review their lives. This is where they're going to be upset, they're going to be sad, thinking back about a lot of memories, sort of going through and reviewing their entire life. The last stage is what we call acceptance, and this is where they actually prepare for death. They've accepted the fact they're going to die. They're not trying to bargain their time. They are preparing for death. When it comes to any type of medical care, especially when it comes to the death and dying process, hospice care, terminal illnesses, different things of that nature, there are going to be legal medical documents relating to their care. And these legal medical documents are going to tell us what we can and we can't do or what the wishes of the patient are. So these are what we call advance directives. Two of the most common types of advance directives are what we call a living will or a durable power of attorney for healthcare. Now, what a living will is, the living will is going to be the patient's wishes on what type of treatments they do or don't want. If they are unable to communicate them due to some type of coma, stroke, or illness. So this is sort of a document that lays out everything that they want just in case they can't communicate it. Whereas the durable power of attorney for healthcare is going to give somebody of the patient's choosing legal rights to make any medical decisions for them if they're unable to communicate. All right, so that's the difference between the two. So a lot of times in the advanced directives, once again, so in the living will, the durable power of attorney, these are going to be people making decisions like, do they want CPR done or not? Do they want a feeding tube? Um, what type of treatment do they want for pain or other symptoms? Do they want equipment such as dialysis machines or ventilators to keep them alive? So we're going to cover all these really important questions that somebody might need to make that decision. So that's where that living will comes into play if they already have these written out or they've given somebody the durable power of attorney for health care. Now, when it comes to advanced directives, no matter what they are, you may still be asked to continue to monitor vital signs and report the readings to the nurse. So, obviously, comfort measures such as pain medications will most likely continue to be used depending on what their advanced directives say. However, depending what those advanced directives state, performing CPR or any other extraordinary measures may be prohibited no matter what the vital signs do, no matter how much the patients decline. We always, by law, have to follow those advanced directives. We always need to make sure that no matter what our personal feelings, beliefs, or thoughts are, those are irrelevant for that patient because those advanced directives are legal documents that we have to follow. Now, typically speaking, you're going to be able to find the advanced directives within the chart. Things like their code status, DNR or full code. So, in the chart is going to have those there for the care team to be able to see and know what those are. So there are going to be different factors that influence feelings and attitudes about death. Now, this can be for the patient that's going through this process. This can be for their family and friends. This could be you as a caregiver and a member of the care team. So experience with death is going to influence feelings and attitudes, personality types, religious beliefs, and even cultural backgrounds, right? Everybody has different experiences with death. Unfortunately, a lot of people have experienced death in their own family at some point in time or with a friend or a close one, a close loved one. And so all of these different factors, our whole life experience is going to play a huge role in how we feel about death, the attitude we have, and how we handle it. When it comes to caring for a patient that is dying, what we need to remember is there are diminished senses. So we want to reduce glare and keep room lighting a little bit low. It doesn't need to be dark, but we want to keep the lighting a little bit low. Hearing is the very last sense to go. So we want to make sure that we continue to talk to our patients and encourage our family to do so as well. I have a really cool story. It literally gives me goosebumps every time I tell it. Is my grandma was a nurse. She worked in the ICU, the ER, neuro ICU. She worked with a lot of critically ill patients. When she worked in the neuro ICU, most of her patients were, in comas, whether they medically induced or from trauma that they sustained. And she would always make it a point that she would always talk to her patients, whether they were conscious or unconscious. Always letting them know what she was doing while she was in there. Oh, it's Thursday. It's nice and sunny out today. It's windy, whatever it may be, just talking to the patient. Because no matter what, we really should be doing this anyway. So this something I want to highlight there is whether our patient is conscious, unconscious, able to communicate with us or not, we should always, always be talking to them. So this is something she always made a point that she thought was important as well, and always talk to her patients. Well, she had one patient she would talk to every day. He had been in a coma for several months. She had been off for the weekend. She got back on Monday, and she was walking down the hall. And she was talking with another nurse or a doctor. And all of a sudden, she heard somebody call out from this room and ask for her to come in. She came in the room, and it was the patient that she had been talking to that was in a coma for several months. Over the weekend, he had woken up. As she was walking down the hall, he heard her voice. And he recognized that voice from when she would care for him and talk to him while he was in his coma. It absolutely amazes me. And he thanked her for continuing to talk to him, that he could hear her. So it just goes to show that hearing is the last sense to go. They can hear you even when they're unconscious. Um, and so we always want to continue to talk to them. Let them know we're there. Let family talk to them. They can still hear us. So hearing is the very last sense to go. We also want to make sure we're taking good care of their mouth and their nose. If a resident is unconscious, they're not eating or drinking, their mouth, their nose, and their lips tend to be get dry and crack. So making sure we're providing mouth care every 2 hours, applying lip balm to the nose and the lips to help keep those hydrated. Making sure we're giving bed baths and incontinence care as needed, making sure we keep the skin clean and dry. Just because they're unconscious, just because they're in the death and dying process, doesn't mean that we still don't give them baths. It doesn't mean that we just let them sit in dirty briefs or depends. So, bed baths and incontinence care are going to be extremely important. Moving them, repositioning them is not going to only help with pain management, it's also going to help with pressure ulcer prevention. So every 2 hours, we should be in there at minimum repositioning them. Comfort is extremely important as well. It's going to be a huge part of pain relief for our patient. Obviously, being a good listener is going to be extremely important when you're assisting patients that are in this death and dying stage. Making sure we're respecting their privacy and their independence, still allowing them to do whatever they're able to do on their own. But with that being said, a lot of people, like I mentioned, want to stay clear of the patients and their family members to give them privacy, but we still have to take care of them and assist them in whatever ways they need that. So we need to respect that privacy and independence, but still make sure we're checking in on them, making sure we're assisting with what they need help with. Obviously, we need to be sensitive to their individual needs as well. So, making sure we're talking to them, being empathetic and understanding, and assisting them with those needs. We also need to be aware of our own feelings. Obviously, when we're dealing with death in any way, shape, or form, um, or we're taking care of anybody, whether death is involved or not, our own feelings can sometimes become present. So we need to make sure we're recognizing where we're at, what our limits are, recognizing our stress, and making sure we're taking good care of ourselves. If we need a break, that we're communicating that to our supervisor. Sometimes it can sort of grow on you quickly. Take a 5 minute break, go take a few deep breaths, take a walk outside, whatever you need to do. Just make sure you're communicating with your supervisor, making sure you're recognizing where you're at and what you need, because this can be difficult to deal with. And most importantly, allow yourself to grieve. This is something that you're going to hear two sides of. You're going to hear people say, don't become attached. Um, you can't let it get to you, but we're human beings, we have hearts. You guys are all entering this field because you care for people, you want to help people. So we're going to hurt. We are going to grieve when we have a patient that passes away. There's no way to turn that off. Um, I know it's hard to not become attached. You care for these patients just like they're part of your family. So it is okay to grieve. It is okay to show emotion. It is okay to cry when a patient passes away. I can't tell you how many times I've cried when I've witnessed or been there when a patient passed away. And you know what? It sort of it shows the family that their loved one affected people outside of their family. Um, you just have to be controlled, right? This can't be a fall on the ground and scream and cry when this happens. But if you have to let a few tears out, that is okay. Once again, we can't help that. We're in this field because we're human beings and we care and we want to help. And when we lose a patient, there is nothing that can stop that feeling. So that is okay. If you need a break, you needed to have time to yourself to allow yourself to grieve. Go take that break. There's going to be times where, you know, this happens and you need a minute to put yourself back together a little bit, to take that time to grieve for a second, to put it back together, and then come back and do what you need to do. So just communicate that. That's happened to me where a patient's passed and I needed to take 5 minutes to just step out, collect myself, maybe talk to my supervisor or another nurse or Cena that was helping care for this patient, just to let it all out. So that's okay to do. Once again, it just has to be professional and controlled. And the biggest thing is communicating to your supervisor about your feelings too. So that way we can help each other through it. We're one big team. It all affects us, in a similar way. So making sure we're all communicating with each other is going to be a huge part of this. But you have to allow yourself to grieve. When someone passes away, as a caregiver, as a SENA, part of our job is to provide postmortem care to our patients. And what postmortem care is care of the body after death. Now, it's going to be extremely important that we're sensitive to the needs of the family after death. Some families may wish to stay in the room and to stay with the patient to say their goodbyes. Um, some may want to step out so we can provide postmortem care and then go back in and say their goodbyes. Every single family, every single patient is going to be different on how this will play out. But it's just important that we're being sensitive and understanding to their needs and to their emotions during this time. Um, there may even be times where the family may want to provide the postmortem care themselves. It's always important that you follow the facility's postmortem care policies on what they're looking for in regards to this. And basically, what we're going to be doing is in postmortem care, we are going to be providing sort of like a bed bath for the patient, cleaning them up, putting them in the clothing that the family or the patient may have requested for them to be in. Now, how we do this is typically after somebody passes, usually the nurse will go up to the family and let them know, if you want to have your goodbyes now, you can. We allow them to have as much time as they want. Once again, we'll offer to give postmortem care, see if they would like to give the postmortem care, ask them when they would like us to do it, and we're sort of going with the flow on what their needs are and their wants are at this time. There's no pressure on our end, and they can have as long as they want to say their goodbyes um, within a reasonable, amount of time. In the next slide, we'll go over sort of exactly what we're going to be doing with postmortem care and the details of it. Once again, postmortem care is bathing the body. And when we're bathing the body, we want to be very gentle, make sure we're avoiding any bruising that could occur. You may need to place drainage pads underneath the patient. When somebody passes away, the body will excrete whatever it has in it, meaning that the patient may urinate, they may have a bowel movement, and so we want to make sure we have drainage pads underneath them um, to to sort of keep the sheets clean and the body clean so that can collect it. It is important that we give that thorough and respectful care. This is the last act of respect that we can sort of do for this patient. It is also important to remember that when a person passes, the muscles in the body are going to become a little bit more stiff and rigid, and it may make it a little bit more difficult to move the body. If the patient has any tubes or other equipment in or on them, we do not want to remove any of that equipment. If the patient does have dentures, you may be instructed to put them back in and close the mouth. Sometimes when patients pass, the mouth may not close all the way, so you may need to roll up a towel or a washcloth and place it under the skin to assist in keeping the mouth closed. You may need to close the eyes carefully as well. When we're finishing with providing this bath, all right, we want to dress them in whatever clothes that if the family's there that they may want them in, or if the resident requested to be dressed in anything specific. We also want to make sure the patient is in a supine position. So that's laying flat on their back with their legs straight, and then their arms will be folded over their abdomen with a small pillow placed under their head. When it comes to the personal items, make sure you just follow your facility's policy on that. It's going to vary from facility to facility on what you're going to do in collecting those items, who to give them to, where to store them, and things of that nature. Now, typically, what happens at most facilities, it's sort of going to depend on the type of facility that you work at. In a hospital, typically the patient will be taken down to the morgue, and then the funeral home will come and pick up the body if an autopsy or anything else does not need to be performed. In the nursing home setting, once the families have said their goodbye and they are ready for the patient to be picked up by the funeral home, the nursing home will call the funeral home, and the funeral home will come and pick up the body. Now, they may need assistance with the body in regards to transferring it to the stretcher, things of that nature. Now, a lot of times, nursing homes do this one of two ways. One is a very private way where they come into the closest exit or entrance. They'll close all the doors in that hallway. They'll go directly into the patient's room, help load the patient on the stretcher, and then take them out the nearest exit. That way, it's not something that people are well aware of is happening. Obviously, death can scare a lot of people, especially those that may be sick. The other way, in the less common way, is some places will do what they call a celebration of life. The funeral home will come in through the front door. Then the staff and residents may line the hall and they clap and celebrate that patient's life on the way out. Now, the first way that I explained is definitely going to be the most common. However, some places do follow the second policy in regards to when a person passes. Just make sure you follow the policy of wherever you work, making sure you're following the rules there. Now, once the patient and the body have been removed, then what we're going to do is strip the beds. We're going to remove all the linen, clean up all those personal belongings, following your policies on what you need to do with them. There may be times where you need to open the windows to air the room and straighten up as well. Some places may have further things that you need to do, but these are the main things that will need to occur for postmortem care. Now, obviously, this can be a very difficult thing to do. Most times, two CNAs or a CNA and a nurse will do this together, as it is very emotionally challenging and can be a very difficult thing to do. So don't be afraid to ask for help. Don't be afraid to, communicate any issues you're having with it. But it is a part of our job as a CNA to help with postmortem care. I remember this is sort of the last act of respect, the last thing we can do to really help take care of our patients. This will end our lecture on death and dying and hospice. So please, if you have any questions at all, please reach out to me at k4@h2health.com. Thank you.